You are at the front line of life-saving medicine. From managing mechanical ventilation and advanced oxygen therapies to navigating complex critical illnesses, this is a field where precision and expertise define outcomes. To excel, you need more than knowledge. You need mastery in applying it under pressure when every second counts. Elevate your expertise. Apply for the fellowship in Respiratory Critical Care. This program empowers you to master mechanical ventilation, advanced respiratory support, and critical care strategies for patients with the most complex conditions. This is not just another training, it's a transformative experience designed for ambitious professionals determined to redefine their practice and impact. Learn from world-renowned experts. Gain clinical insights, practical pearls, and the latest evidence, all accessible from wherever you are. Our curriculum is comprehensive, covering the full spectrum of respiratory and critical care, from invasive and non-invasive ventilation, ARDS, and sepsis management, to ECMO and advanced rescue therapies. You'll gain practical, actionable expertise. Engage in live, interactive sessions, present your toughest ICU cases, collaborate with peers across the globe who share your passion for saving lives. This is your chance to strengthen your expertise, expand your career horizons, and join a community dedicated to excellence in respiratory critical care. The future of respiratory critical care is here. Are you ready to lead it? Applications are now open. Visit our website to begin your journey today.
Hello, everyone, and welcome to our Respiratory Critical Care Fellowship webinar. Today, we have a very special webinar and very hot topic and debate on high-flow nasal cannula usage and type 2 respiratory failure, hypercapnic respiratory failure. We have great speakers and moderators today. Professor Hibatullah Asal, she's a professor of chest medicine in Cairo University, and Dr. Shireen Nassar, she is a lecturer of chest medicine at Cairo University, Egypt. Professor Fadi Al-Jam'an from King Saud University in Kingdom of Saudi Arabia, and Professor Sultan Al-Ammari, and also Professor Ashraf At-Tarifi. So we have 20-minute presentation by Dr. Hibatullah Asal. She's going to talk about the upside of using high-flow nasal cannula in type 2 respiratory failure. Then the debate will go on with Dr. Fadi Al-Jam'an. He will give another 20-minute presentation on the downside of using high-flow nasal cannula in type 2 respiratory failure. Then we'll have about 10-minute case-based discussion by Dr. Shireen Nassar. Again, Dr. Sultan Al-Amri and Dr. Ashraf At-Tarifi are going to moderate the session and trying to help our speaker to moderate and answer the question. Again, very special guest speakers. They are not really guests. They are owners and founders of our Respiratory Critical Care Fellowships. They are cornerstone and key person in this fellowship. And just housekeeping stuff here. If you have any question, feel free to type it in the QA box. All attendees should receive certificates early next week. And if you want to see the transcribed lectures, you can activate or enable the show caption option in your screen so you can both hear and see the transcribed lectures. If you haven't joined our 1 year online respiratory critical care fellowship yet, please go ahead and do. It's very informative and it's accredited by the American Association of Continuing Medical Education. And there is a promo code especially for this webinar. You can use promo code 10RCC, which stands for Respiratory Critical Care. So 10RCC to get 10% discount. Again, all of this knowledge that we are offering and trying to help you is just to improve your clinical practice. And the great aim of education is not the knowledge itself, but the action. So hopefully the knowledge that you are gaining in this webinar is going to help your patient's outcome. With that, we are going to listen to our great first speaker, Dr. Hibatullah Asal, and she's going to talk about the pros of using high-flow nasal cannula in type 2 respiratory failure.
Good evening, everyone. My name is Hibatullah Asal, Professor of Chest Diseases, Cairo University. Today, I'm going to talk about the pros of use of high-flow nasal cannula in hypercapnic respiratory failure. Points to be covered in the lecture. I'm going to talk about the physiological rationale in using such modality in these patients. The high-flow nasal oxygen as initial treatment of acute hypercapnic respiratory failure, whether the patient has respiratory acidosis or non-acidotic respiratory failure. High-flow nasal oxygen as post-extubation respiratory support strategy in patients at risk of hypercapnia. The use of domiciliary high-flow nasal cannula in stable hypercapnic COPD, and future perspectives regarding the use of the asymmetrical nasal interface. First of all, the concept of using high-flow nasal oxygen, the first advantage is that it provides a high gas flow. This high gas flow rate meet or exceed the patient's peak inspiratory demand, eliminating the dilution of oxygen from room air. So it ensures the delivery of fixed fractional inspired oxygen concentration with limited dilution of inhaled gas, although the patient is tachypnic and has high inspiratory demands. It also facilitates carbon dioxide washout from the anatomical dead space of the upper airways, which favors ventilatory efficiency and reduces the work of breathing. This effect is proportional to gas flow, but it reaches a plateau after 30 to 40 liters per minute, so it's not recommended to put the flow above 40 liters in patient with hypercapnic respiratory failure in order not to increase the peak inspiratory pressures of the airway. The high flow provides a flow-dependent positive end expiratory pressure of 2 to 5 centimeter water, especially when the mouth is closed. This helps counterbalance intrinsic PEEP caused by dynamic hyperinflation due to altered elastic recoil of the lung. The delivery of actively heated and fully humidified gas improves mucociliary clearance, moistens bronchial secretions, improving cough effectiveness. As we all know that the patient intolerance is the main factor limiting the use of non-invasive ventilation, as usually the patient is anxious, tachypnic, and claustrophobic. Sometimes the patient, due to prolonged use of non-invasive ventilation, has skin ulceration and significant lesions that lead to air leaks and patient-ventilator asynchronies. High-flow nasal oxygen is characterized by better tolerability and patient comfort compared to face mask in non-invasive ventilation. What about the optimal settings of high-flow nasal oxygen in hypercapnic patients? Inhaled FiO2 should be adjusted to obtain saturation between 88 and 92%. And as we said, that flows exceeding 40 liters per minute may not be needed and could even be contraindicated because they do not confer additional advantage on CO2 clearance, but may be associated with worsening hyperinflation due to excessive increase in expiratory resistance. So the best flows should be ranging between 30 to 40 liters per minute in hypercapnic patients. To summarize, the physiological benefits of this modality is the carbon dioxide washout from the anatomical dead space, is the PEEP effect, so improving the intrinsic PEEP of the patient, the improvement of ciliary function due to heated and humidified gas, and the precise delivered fractional of inspired oxygen due to high flow rates that meet the patient's peak inspiratory demand, limiting the dilution of oxygen, the patient comfort as compared to the use of non-invasive ventilation mask, and improved efforts, reduced respiratory rate and large tidal volume. However, the high flow nasal cannula does not support good support to the respiratory muscle fatigue. The non-invasive ventilation is more effective in reducing the workload in the respiratory muscles during the acute respiratory failure. So non-invasive ventilation always remains the first line choice in these patients. And maybe rescue non-invasive ventilation may be needed because of the pressure support that unloads the fatigued respiratory muscle is supported by the non-invasive ventilation and not supported by the high flow nasal cannula. So we are going to summarize some of the studies that studied the use of high flow nasal cannula as initial treatment of acute hypercapnic respiratory failure. And in this study, the patient with COPD and had exacerbation with stable phases. This means that they were not acidotic. They did not have respiratory acidosis. This was a systematic review and meta-analysis published in 2023, compared between both modalities in 1,864 patients in COPD stable exacerbation with no acidosis, and they found no difference between these treatments in terms of intubation rate and in terms of oxygenation, carbon dioxide, and barotrauma. And the high flow nasal oxygen was associated with better patient comfort compared to non-invasive ventilation. Patient with acute exacerbation who are hypercapnic and acidotic. This study published in 2020 in Critical Care Journal. It's a trial that was comparing between the high flow nasal cannula and the non-invasive ventilations regarding the difference in PaCO2 from the baseline after 2 hours of treatment. And the high flow nasal treatment was statistically non-inferior to non-invasive ventilation as initial ventilatory support in decreasing PaCO2 after 2 hours of treatment in patients with mild to moderate acute exacerbation of COPD. However, the drawback of this study is that 32% of patients receiving high flow nasal treatment required non-invasive ventilation after 6 hours. This was published in 2022 in Critical Care Journal, a systematic review and meta-analysis comparing the high flow nasal cannula versus the non-invasive ventilation in acute hypercapnic respiratory failure, and they found no difference in mortality and intubation rate or length of hospital stay between the two modalities. A more recent study in 2024 in Critical Care Journal, a randomized controlled trial, including 225 patients diagnosed with acute exacerbation of COPD with respiratory acidosis and hypercapnia, were randomly assigned to high flow nasal cannula or non-invasive ventilation, and the failure rate of the high flow nasal cannula was significantly greater. It was 25% versus 14.3% in non-invasive group. So there were high instances of treatment failure in patients using high flow nasal cannula acute exacerbation with acidosis. So there are contradictory literature results and debatable results according to different studies. However, the European Respiratory Society had suggested in these patients with acute hypercapnic respiratory failure to use first a trial of non-invasive ventilation prior to the use of high flow nasal cannula in these patients. So in these patients, the non-invasive ventilation is still the superior modality. However, the high flow nasal cannula still has a place in some of these patients that do not tolerate the non-invasive ventilation. So non-invasive ventilation remains the cornerstone intervention to revert hypercapnia in patients with acidosis. High-flow nasal cannula could be attempted in patients failing non-invasive ventilation because of discomfort. However, it requires close monitoring, as well as patients that are treated with non-invasive ventilation and needs break in between, example for speaking, drinking, eating. The high-flow nasal cannula here will be safely and effectively used between sessions of non-invasive ventilation. So again, individual patient factors play an important role in choosing which respiratory support should be adopted. So non-invasive ventilation is relatively contraindication in patients with excessive secretions, with abnormal facial structure or excessive hair that result in air leaks. The patient has poor compliance. The patient is claustrophobic. Here, the high-flow nasal cannula should be used with close monitoring. And in patients with increased work of breathing, respiratory muscle fatigue, congestive heart failure, here the positive pressure of the non-invasive ventilation may positively impact hemodynamics and is preferable than the high-flow nasal cannula. So each patient should be tailored and monitored according to his status. Now we are going to discuss the high-flow nasal cannula as post-extubation respiratory support in patients at risk of hypercapnia and increased risk of re-intubation. So failure of weaning from mechanical ventilation is defined as the need for re-intubation within 2 to 7 days after extubation. This occurs in about 10 to 20% of patients who are extubated after a successful spontaneous breathing trial. And of course, we all know that these patients that are subjected to re-intubation have increased significant incidence of mortality. What are the predictors of extubation failure in such patient? If the patient is old age, congestive heart failure, severe COPD with high disease severity scores, BMI above 30, increased bronchial secretions, difficult breathing, 2 or more comorbidities with a prolonged duration of mechanical ventilation, all of these factors put the patient at high risk of post-extubation respiratory failure and re-intubation with increased risk of mortality. So this study was done on these patients, the inclusion criteria, the patient that had more than 4 of these risk factors and were planned for extubation were included and were randomized to undergo either non-invasive ventilation with active humidification or high-flow nasal cannula for 48 hours after extubation. And the primary outcome here was the re-intubation rate within 7 days after extubation. And again, here the non-invasive ventilation was superior than the high-flow nasal cannula, where the re-intubation was required in 23% of patients receiving a non-invasive ventilation versus 38% of those receiving high-flow nasal cannula. Hospital length of stay was lower in those patients treated with non-invasive ventilation. So, among adult critically ill patients at high risk for extubation failure, non-invasive with active humidification was superior to high-flow nasal cannula for preventing re-intubation. And here the ERS clinical practice guidelines did recommend the high-flow nasal cannula in non-surgical patients after extubation if the patient has no risk of re-intubation. So here the high-flow nasal cannula is preferred over the conventional oxygen therapy. However, for non-surgical patients with high risk of extubation failure, having more than 4 of the risk factor that we've mentioned, so here the non-invasive ventilation is preferred than the high-flow nasal cannula for such patients. Another type of patient are the stable hypercapnic COPD patients that are prescribed long-term oxygen therapy. The question is, would domiciliary high-flow nasal cannula or the home use of high-flow nasal cannula devices would be beneficial in such patients? And this study was done to answer this question where 104 participants. This study was published in the American Journal of Respiratory Critical Care Medicine in 2022. And they included 104 participants with daytime hypercapnia, and these patients were already receiving long-term oxygen therapy for more than 16 hours a day for more than 1 month, and they were randomly assigned to receive either high-flow nasal cannula treatment alternating with conventional oxygen or patient receiving conventional oxygen only. The patient that were receiving the high flow nasal cannula treatment, they received it for more than 4 hours per night during sleep, as per study protocol, at flow rates of 30 to 40 liters per minute, combined with long-term oxygen during the daytime if they preferred, and the other group remained on long-term oxygen for more than 16 hours a day. And here the high flow nasal cannula significantly reduced the rate of moderate to severe exacerbation and improved health-related quality of life scores, peripheral oxygen saturation, and specific pulmonary function parameters, and no safety concerns were identified in this study population. However, the question is about the cost effectiveness of such expensive device, whether use of an expensive device at home would be beneficial. And one recent cost effectiveness analysis of domiciliary use with high flow nasal cannula therapy and conventional oxygen found that high flow nasal cannula therapy for patients with COPD could provide substantial hospital cost saving over the 5-year survival period. So although the device is very expensive, however, it would decrease the cost saving for hospital admission, for exacerbation, and of course would have beneficial effect on the patient, causing decrease in exacerbation rate. So consider the cost effectiveness of high flow nasal cannula therapy. Identifying the patients who might benefit the most from domiciliary high flow nasal cannula therapy is crucial. Now we are going to talk about future perspectives, which is the use of asymmetrical nasal interface. The concept of using symmetrical versus asymmetrical interface is using a large bore, a nasal cannula. This causes increase in pressure in one of the nasal orifices, increasing the positive end expiratory pressure without occluding both nasal opening. So here we minimize the leak and occlude one opening, causing increase in positive end expiratory pressure, and the other nasal opening it should not be occluded to prevent the deleterious effect of increasing pressures in such patients. This is the symmetrical nasal high flow interface, where it creates circulating flows in each cavity and dilute and purge expiratory gas from the dead space to escape through both nostrils. And this is the asymmetrical nasal interface, where sealing of a large bore to the nostril, which generate higher PEEP than conventional cannulas. A symmetrical interface increase PEEP without fully occluding the airway. Other advantage is that asymmetrical interface creates a pressure gradient and asymmetrical flows between nasal cannula, where between the nasal cavities, where one cavity has lower pressure than the other. So this flow quickly purges expired gas through the less occluded nair with less pressure. They found that this difference in pressure quickly purge the air through the less occluded nair and quickly washes out the CO2 than the conventional symmetrical cannula. And this study was done to study the effect of the asymmetrical high flow nasal cannula in hypoxemic patient, and it was found that the application of innovative asymmetrical pronge in patient with hypoxemic respiratory failure was demonstrated to improve carbon dioxide clearance and reduce minute ventilation and work of breathing compared to classical symmetrical cannulas. So to summarize, the high flow nasal cannula therapy can be an alternative respiratory support to non-invasive ventilation for COPD patients with mild to moderate hypercapnia to avoid intubation during initial treatment and re-intubation after extubation. Close monitoring is needed to identify the timing for treatment escalations. The utilization of high flow nasal cannula therapy in the domiciliary setting may have more potential benefits for COPD patients with chronic hypercapnic respiratory failure than long-term oxygen therapy. Large-scale randomized controlled trials are required to strengthen the evidence for the application of high flow nasal cannula therapy in patients with COPD at different trajectories. And thank you. Okay, thank you everyone for being with us. And I hope this small presentation would be informative. Now we are Now it's turn of the cones. What about the cones of high flow nasal cannula in use in a patient with hypercapnic respiratory failure? And now we have Professor Fadi Al Jam'an, Associate Professor of Respiratory Critical Care, King Saudi University, Saudi Arabia, will discuss the cones of using high flow nasal cannula in hypercapnic respiratory failure.
Good evening, everyone, and thanks for attending our webinar. So let's talk now about the use of the high flow nasal cannula in hypercapnic respiratory failure, but we will talk from the cons side or the uh, possible or potential disadvantages. Let's start by talking briefly about the mechanism of hypercapnia or hypercapnic respiratory failure. So, hypercapnic respiratory failure is characterized by the arterial CO2 level, which is higher than 50 millimeter mercury. Hypoxemia is a very common, or it's usually common, also presentation with the hypercapnia, especially with significant hypercapnia. Hypercapnic respiratory failure mechanism is either reduction in the ventilatory capacity or in the minute ventilation, or there is an increase in the dead space ratio to the alveolar ventilation. So therefore, the main mechanism by the end for the hypercapnia is failure of the ventilatory pump to match the carbon dioxide clearance. Now, hypercapnia is a common presentation or common failure, respiratory failure for patients who have neuromuscular diseases because as it's a common sense that they have involvement of the respiratory muscles and eventually they have pump or ventilatory failure. And additionally, also it's a common presentation for patients who have advanced obstructive lung disease, mainly COPD, due to the bronchospasm, which will lead to air trapping, consequent hypoventilation, and incremental rise in the dead space ratio. And this is especially for patients who have advanced emphysema, patients who have bolus emphysema. So, non-invasive ventilation, especially when we talk about the BiPAP, has been shown historically to be significantly superior to other methods or to other ways of managing hypercapnic respiratory failure, especially to the high flow nasal cannula, which was introduced recently. And especially on the short term or in the acute hypercapnic respiratory failure. And it has been associated to be associated with improvement of the long-term outcome of these patients. So, with the introduction of the high-flow nasal cannula, there has been growing evidence supporting the application of the high-flow nasal cannula for patients of hypoxic respiratory failure. But then, with the introduction of the high-flow nasal cannula for patients with hypoxic respiratory failure, then there was a trend of using or trials of using the high-flow nasal cannula for patients with hypercapnic respiratory failure. So there is an evidence, as Dr. Heba, she has shown for the acute hypercapnic respiratory failure and chronic hypercapnic respiratory failure, but still the use for the acute hypercapnic respiratory failure is insufficient and controversial. And the non-invasive ventilation is recommended as a first-line respiratory support method for patients who have acute hypercapnic respiratory failure, especially those who have associated acidosis. So now, if we go to the guidelines from the 2017 from the American Thoracic Society and European Respiratory Society for the use of the non-invasive ventilation for patients who have acute respiratory failure. So as we can see here, that it was suggested that non-invasive ventilation in patients who are not acidotic and having COPD, that it's not really recommended for those patients when they have hypercapnia to be treated with non-invasive ventilation, which was a conditional, not really high level of evidence. And this recommendation was more for those patients, as we said, for the hypercapnia not associated with acidosis. While the recommendation for patients who have acidosis and whether they have acute or acute on top of chronic respiratory failure, and when they have a pH less than 7.35, there was strong recommendation with high certainty of evidence to use the non-invasive ventilation, because those patients, there was strong recommendation that non-invasive ventilation was associated with less requirement of endotracheal intubation and use of mechanical ventilation for those patients. As we can see that the preferred choice for those patients is to use the non-invasive ventilation. This was according to the recommendation from the 2017. And there was no clear limit for the lower pH limit when to use the non-invasive ventilation, but the lower the pH, the greater the risk for respiratory failure, and the closer the patients for need of endotracheal intubation and mechanical ventilation. So if we go now to the most recent evidence evaluating the use of the high-flow nasal cannula in hypercapnic respiratory failure. So this is a systematic review and meta-analysis from 2025. So it was evaluating the use of the high-flow nasal cannula versus non-invasive ventilation, comparing them regarding the drop of the CO2, regardless of the pH level, whether it was higher than 7.35 or less than 7.35. And there was trend of better pH improvement with non-invasive ventilation. So according to this systematic review, the high flow nasal cannula and non-invasive ventilation, they were comparable regarding the outcome of the drop of the CO2, but there was trend of better pH improvement for patients who were on non-invasive ventilation. And there was no benefit of high flow nasal cannula over non-invasive ventilation regarding the improvement of the hypoxia or the respiratory rate improvement or the heart rate or the Borg scale for the perceived exertion or the visual analog scale for the comfort level or respiratory support. And there was no difference regarding the duration of the support or the hospital stay or mortality or the rate of endotracheal intubation or treatment failure. But for the patients who had pH of less than 7.35, there was trend of less treatment failure for the patients who were treated with non-invasive ventilation compared to those who had high flow nasal cannula. So again, I'm stressing that the patients who were more acidotic or more acidemic, to be honest, they had less treatment failure when they were treated with non-invasive ventilation compared to the high flow nasal cannula. Now, to investigate more the potential possible failures of the high flow nasal cannula and hypercapnia, let's talk about the pathophysiology of how the high flow nasal cannula would manage the hypercapnia. So one of the potential benefits from the high flow nasal cannula is the PEEP effect generated by the high flow nasal cannula. So high flow nasal cannula can antagonize the bronchospasm that's actually augmented in the patients who have COPD, especially in the exacerbation status, when they have high airway resistance. So this generated PEEP, it will actually antagonize this high airway resistance, and it will relieve the patient's discomfort and the respiratory muscle fatigue. And in that way, it will actually relieve their fatigue and it will actually improve their minute ventilation, and eventually it will improve their CO2 clearance. But this PEEP effect, which is generated by the half nasal cannula, it's actually variable and depends on the flow which is actually set on the half nasal cannula, size of the nasal pons, which is related to the size of the nostrils, and the best achieved PEEP by the high flow nasal cannula is actually 5 to 7 millimeter mercury with the mouth closed. If the mouth was open, then the PEEP drops to 1 centimeter mercury, and all the PEEP actually effect is lost. Therefore, opening the mouth by the patient will actually lead to the loss of all this PEEP effect generated by the high flow nasal cannula. So if we actually go in more details, according to that actual review article, which investigated the effects of the flow setting during the use of the hyperonic cannula and this systematic review. So they evaluated patients that they were actually using hyperonic cannula, whether their mouth was closed or their mouth was open. So they found that studies which have used the hyperonic cannula with the genetic PEEP, it led to improvement in the lung recruitment, mainly in the dependent lung regions. But this improvement in the lung recruitment was variable. In some studies, it showed, or some patients, it showed some improvement. Others, they actually showed that there was no difference in the improvement of the lung recruitment. And even in some patients, it showed that there was overdistension of the non-dependent lung regions, especially in the upper lung zones, because of the PEEP effect, which was unjustified or unneeded in those well-inflated upper lung regions. This variability in the PEEP effect in those patients was explained mainly by the mouth status, whether it was closed or open. So as we can see here, that the patients who had open mouth, they had low PEEP effect, while the patients who had closed mouth, so they had good generated PEEP, which led to good improvement and even sometimes, as I said, over distension of the upper lung regions, especially with the flows, which was above 60 liters per minute, that was associated with over distension most of the time. So let's switch now to another mechanism of the hyperonic cannula potentially improving the CO2 clearance is actually washing out the dead space mainly in the upper airways. But so the dead space in patients, especially with the COPD, it's actually a high dead space, especially while they are in exacerbation. Now, what's the usual amount or value of the dead space in the healthy patients? Actually 40 to 50 ml, which comprises only 30% of the anatomical dead space in the normal person. But in the patients who have COPD, especially when they have exacerbation, the dead space ratio or value increases tremendously compared to the healthy subjects. Therefore, washing out the upper airway dead space contribute minorly, theoretically, to reducing the CO2, especially in the patients who have moderate to severe hypercapnia. If we add to that another value, which is actually related to the mouth status, because washing out the dead space or the upper airway dead space needs that the mouth should be kept open, because otherwise the hyperonic will not be able to wash out the dead space. So as we said, washing out the upper airway dead space necessarily needs the mouth to be kept open to make the hypernasal cannula effective. So as we can see in those studies that when the mouth was actually kept closed, the CO2 clearance was actually low, while the patients who had the mouth kept open, there was high CO2 clearance. So we have two potential mechanisms for the hypernasal cannula to manage the hypercapnia that they antagonize each other's. The PEEP effect, which means that the mouth should be kept closed, while at the same time the wash out of the dead space, which means that the mouth should be kept open, which they actually go in opposite direction from each others. Now, if we talk about the main advantage regarding the high flow nasal cannula, which is improving the patient comfort, even though the high flow nasal cannula inspiratory flow may improve the patient's comfort and relieve the discomfort generated by non-invasive ventilation, but on the other side or other hand, there is evidence that the high flow nasal cannula, through the pressure which is generated from it, it can actually increase esophageal pressure, especially with the high flows generated. When we are talking about flows above 40 liters per minute, reaching 60, or even sometimes higher flows, higher than 60s, they were used mainly on research side. So these high flows, they were actually associated with high esophageal pressure, and at the same time, this high esophageal pressure, it led to drop in the lung compliance, over distension of the lung, and causing even action on the other side, more discomfort to the patient, and even raising concerns about potential lung injury. So if we look at this study, which actually looked at the patient's esophageal pressure, and at the same time the flows generated by the high flow nasal cannula, they found actually in this systematic review looking at different studies. In one of the studies, they found that increasing the flow, it was actually associated with no drop in the esophageal pressure, with increasing the flow. So drop in the esophageal pressure actually means that there is improvement in the compliance, while increasing the flow with no drop in the drop esophageal means there is improvement in the compliance, while there is no drop, it means that there is no lung recruitment and there is no improvement in the esophageal pressure. So if we talk about the work of the breathing, and if we talk about the pressure time product, which actually give us a better look about the patient comfort when using any method of ventilation, especially when we talk about the high flow nasal cannula here, we can see that in some studies, like in this study here, and in this study here, that using the high flow nasal cannula, it might be associated with increasing the work of the breathing, or might be associated with increasing the pressure time product, which is a surrogate for the respiratory muscle work. So therefore, high flow nasal cannula, it might be associated with increasing the patient discomfort, and not all the time is actually improving the patient comfort, as it might be kept in our mind all the time, especially when we talk about the high flows, which are needed for washing out CO2, for washing out the dead space, and which are needed for generating the PEEP effect. So let's talk about this systematic review, which was comparing the high frequency cannula to non-invasive ventilation in patients with hypercapnic respiratory failure. So they found that regarding the change in the CO2, there was no improvement in the high frequency cannula compared to the non-invasive ventilation in relation to the drop in the CO2, no significant improvement. When they looked at the pH actually improvement, there was no significant change in favor of the high frequency cannula compared to the non-invasive ventilation. Even regarding the hypoxia, the high frequency cannula was not really superior to the non-invasive ventilation. So high frequency cannula, it might be a final exhaustive measure for patients with COPD, acute hypercapnic respiratory failure, when non-invasive ventilation is not tolerated by the patient, or the patient is not clinically indicated to be upgraded to endotracheal intubation, because they were comparable. But high frequency cannula was not superior by any parameter, or any measure was not superior to the non-invasive ventilation. One of the major challenges is how to titrate the high frequency cannula, especially when we talk about managing hypercapnia. Would we titrate the high flow nasal cannula according to the pH? As we have shown that the high flow nasal cannula was not really associated with better outcome when we talk about the patients who had acidemia and pH less than 7.35. So actually, patients who they did better when they were put in non-invasive ventilation. Would we treat patients according to their CO2 level? Would we treat them according to their bicarbonate level? So we have to keep in our mind that the high frequency cannula, it might deceive the clinician, and over reliance on the high frequency cannula, especially if we use the pH as we have shown, it might actually give the clinician a false impression that he's actually doing a favor for his patient, but he might be just spending time and delaying the end point of giving the real support, the necessary support of non-invasive ventilation, or even sometimes he's delaying necessary intubation. Now, evidence has shown that the patients who had hypercapnia with high bicarbonate level, regardless whether it was associated with acidemia or not associated with acidemia, when they were treated with high flow nasal cannula, they were associated with prolonged length of stay in the hospital. So in this study, they found that the patients who were treated with either conventional oxygen therapy or high flow nasal cannula, and when they had high bicarbonate level or low bicarbonate level. So when they had high bicarbonate level, they actually had prolonged length of stay, especially when they were treated with high flow nasal cannula. They had prolonged length of stay. But why did they do that? Why did they behave like this? It's actually because those patients eventually they had lower escalation to the non-invasive ventilation, and they were just delaying the end point or the point of switching them to the real necessary support of non-invasive ventilation. And this actually high bicarbonate level was pointing to a high level of CO2, and they needed the non-invasive ventilation to drop realistically their CO2, high CO2 level. Another actually study to have a look at is comparing the high flow nasal cannula versus non-invasive ventilation patients with COPD. The primary objective was non-inferiority for the drop of at least 10 millimeter mercury of CO2 level, and they found that there was no significant difference in the reduction of the CO2 level between the high flow nasal cannula and the non-invasive ventilation from the baseline up to 2 hours, and there was comparable difference in the drop of the CO2 level. It was about like 6.8 millimeter mercury in the high flow nasal cannula to a drop of 9.5 millimeter mercury in the non-invasive ventilation. There was no significant difference between both of them. But keep in our mind that 32% of the patients receiving the high flow nasal cannula, eventually, after 6 hours, they were actually required non-invasive ventilation. So high flow nasal cannula improved the drop in the CO2 up to 2 hours, but it could not maintain that improvement in the CO2 drop up to 6 hours. And third of the patients, they required after 6 hours switching them to non-invasive ventilation. So if we talk about the most recent guidelines by the ERS regarding the use of the high flow nasal cannula acute respiratory failure, so as we can see here that we suggest trial or non-invasive ventilation prior to the use of the high flow nasal cannula for patients with COPD and acute hypercapnic respiratory failure. And even though it's actually a conditional recommendation with no certainty of evidence, but they could not recommend using the high flow nasal cannula as initial management for those patients, but to start with non-invasive ventilation before using the high flow nasal cannula for patients with COPD or acute hypercapnic respiratory failure. Especially when we talk about the patients who have pH less than 7.35, and those who are requiring endotracheal intubation or mechanical ventilation, they have to be started on non-invasive ventilation. And their recommendation that high flow nasal cannula has a rationale for use in a hypercapnic COPD exacerbation because of its ease of use and the patient's comfort, making it alternative to non-invasive ventilation for acute and chronic respiratory failure, chronic hypercapnic respiratory failure, but only in mild to moderate, not severe degree of respiratory failure, and those who are not associated with respiratory acidosis. However, its use in the acute hypercapnic respiratory failure is not really well established according to the most recent evidence. So, in summary, high flow nasal cannula it might be non-inferior to the non-invasive ventilation in managing only certain population of hypercapnic patients, especially those who have chronic respiratory failure, chronic hypercapnic respiratory failure, and those who have mild to moderate acute hypercapnia, and they have no significant distress, and they are not really close to endotracheal intubation. This use of the high flow nasal cannula should be under close monitoring of their effort, close monitoring of their pH, close monitoring of their CO2 level and the drop in the CO2 level. High flow nasal cannula has not been shown, according to the studies, to reduce mortality or the length of the stay. Even it might actually be associated with extending the length of the stay because it might delay the use of non-invasive ventilation and deprive the patients from such support and increase the rate of intubation. Studies that had evaluated the use of high-flow nasal cannula and hypercapnic respiratory failure did not really investigate precisely the mortality and the length of the stay, and therefore there is no clear evidence in that regard. High-flow nasal cannula has better compliance and patient comfort compared to non-invasive ventilation generally. And so far, there is insufficient evidence to make general recommendation for the use of high-flow nasal cannula, given that there is high certainty of evidence so far from a very rich literature of using the non-invasive ventilation in COPD patients, especially when we talk about acute, severe hypercapnic respiratory failure for those patients. High-flow nasal cannula, it might be excellent choice for patients who are not tolerating non-invasive ventilation or patients who are not candidate for being upgraded to mechanical ventilation and endotracheal intubation. And thank you very much.
Thank you, Professor Fadi, for this excellent presentation with very nice and rich scientific evidence. Now it's the turn of Dr. Shireen Nassar, lecturer of chest diseases, Cairo University. She's going to handle two case scenarios regarding the use of the two modalities in patients with hypercapnic respiratory failure.
Good evening, everyone. I'm Dr. Shireen Nassar, lecturer of chest diseases, Cairo University, Egypt. And today I'll be presenting a case-based discussion on high-flow oxygen therapy in patients with hypercapnic respiratory failure. I hope this session would be interactive, informative, and clinically relevant for you all. So the first case we have is for a 68-year-old man presenting to the emergency department with worsening dyspnea, productive cough, and fatigue over the past 3 days. His past history includes COPD with frequent exacerbations, his GOLD Group E, more than 2 hospital admissions in the past year, 40-pack year smoking history. Patient is on LABA/LAMA inhalers with intermittent inhaled corticosteroids. On examination, patient appears to be drowsy but is arousable, respiratory rate 32, heart rate is 112, blood pressure 140/85, SpO2 84% on room air, with the use of accessory muscles. By auscultation, there is diffuse wheeze and reduced air entry. This is his chest x-ray. As we can see here, there are clear signs of hyperinflation with hyperloosened lung fields bilaterally, lowered and flattened diaphragm, together with elongated and narrowed cardiac silhouette. His initial ABG on controlled oxygen via nasal cannula 2 liters per minute. His pH is 7.3, PaCO2 is 65 millimeter mercury, PaO2 is 53 millimeter mercury, and bicarbonate level is 32 milliequivalent per liter. So the first question, what is the most accurate interpretation of this ABG? Is it A, acute respiratory acidosis, B, chronic respiratory acidosis, C, acute on top of chronic hypercapnic respiratory failure, or D, metabolic acidosis with compensation, or E, type 1 respiratory failure? Correct answer is C. It's acute on top of chronic hypercapnic respiratory failure, as the patient's pH is 7.3, which is lower than the normal range. We all know 7.35 to 7.45, indicating acidosis. The PaCO2 is elevated, is 65 millimeter mercury, causing the lowering in the pH, respiratory acidosis. The bicarb level is 32, suggesting a chronic process going on. The normal range is from 22 to 26 milliequivalent per liter, with the PaO2 level of 53, which is low, of course, indicating hypoxemia. Second question, what do you think is the most appropriate initial respiratory support? Is it A, high flow nasal oxygen, B, conventional oxygen therapy targeting more than 96%, C, NIV, or D, immediate intubation? Correct answer is C, it's non-invasive ventilation, as it improves alveolar ventilation, offers the reduction in PaCO2 levels with the inspiratory positive airway pressure and the expiratory positive airway pressure applied, which are leading to the reduction in the intubation and mortality rates among such cases. High flow nasal oxygen may be used in non-acidotic, which is not the case here, or NIV intolerant patients, but it's not recommended as first line in such cases as we have in this case. Third question, which findings suggest NIV failure? Is it improved pH? B, decreased PaCO2, C, persistent or worsening acidosis, D, improved mental status, or E, reduced respiratory rate? Correct answer is C, persistent or worsening acidosis. Other key NIV failure signs include worsening pH, rising PaCO2, persistent tachypnea or distress, reduction in the consciousness level, and poor mask tolerance. The second case we have is for a 72-year-old man presenting with increased dyspnea and productive cough for 2 days. His past history includes COPD, but with infrequent exacerbations. His GOLD group B. Patient is hypertensive, and he had history 2 years ago of poor tolerance to NIV with mask intolerance and severe anxiety. On examination, patient is alert, he's mildly distressed, respiratory rate is 26, heart rate is 102, blood pressure 135/80, SpO2 is 88% on room air with mild use of accessory muscles with diffuse wheeze by auscultation. His initial ABG on 2 liters oxygen, pH is 7.37, PaCO2 52 millimeter mercury, which is high of course. PO2 is 60, bicarbonate level is 29, but the pH is 7.37, so it's compensated hypercapnic respiratory failure as the pH is in the normal range. The first question, what do you think is the most appropriate initial respiratory support for such patient? Is it A, immediate intubation, B, BiPAP or bilevel ventilation, C, high flow nasal oxygen or oxygen therapy, D, conventional oxygen therapy targeting SpO2 100%, or E, CPAP? Correct answer is C, high flow oxygen therapy. It's appropriate as the patient is hypercapnic but without acidosis. He has mild to moderate respiratory distress with history of NIV intolerance, which is an important real-life factor. However, NIV may be preferred if the patient had acidosis, but here high flow oxygen therapy is a reasonable option. Second question, what are the main physiological benefits of high flow oxygen therapy in hypercapnia? Is it full ventilatory support? B, dead space washout? C, high PEEP comparable to NIV? Or D, complete CO2 elimination? Or E, suppression of the respiratory drive? Correct answer is B, with high flow oxygen therapy washing out the nasopharyngeal dead space. Question 3, which statement best describes the PEEP effect of high flow oxygen therapy? A, it provides high and fixed PEEP. B, no PEEP effect. C, provides low variable PEEP around 2 to 3 centimeter water. Or D, it provides PEEP equivalent to the NIV PEEP. Correct answer is C, it provides low and variable PEEP, usually below 5, around 2 to 3 centimeter water, depending on the flow set on the device and the mouth position. So the PEEP provided is usually low and variable. Which of the following represent the most appropriate settings you would adjust for this patient for FiO2 and the flow? Is it A, FiO2 targeting 94 to 98 with flow 50 to 60? Or B, FiO2 88 to 92 targeting SpO2 or flow with flow 40 to 60? Or C, targeting saturation 88 to 92 with flow 30 to 40 liters per minute, or D, FiO2 targeting 100% SpO2 with flow 30 to 40 liters per minute. Correct answer is C, targeting 88 to 92% with flow 30 to 40 liters per minute, as 30 liters per minute is usually an optimal starting range. It provides adequate CO2 washout with less risk of dynamic hyperinflation, and flows with higher than 40 liters per minute provide no additional CO2 clearance and can actually worsen the air trapping and dynamic hyperinflation, increasing the expiratory resistance. This diagram, adapted from Frat et al. In 2017, provides it illustrates the effects of high flow oxygen therapy in expiration, providing the PEEP, alveolar recruitment, and dead space washout, as we mentioned, inspiratory with meeting the demands of the patient with peak inspiratory flow coverage and high FiO2, the humidification and heating, all of it contributing to reduction in the respiratory effort and reduction in the respiratory rate and work of breathing of the patient, as the high flow oxygen therapy deliver heated and humidified gas, preventing airway drying, maintaining mucociliary function, reduction in the thick secretion formation, and improvement in the secretion clearance and airway patency. All of these effects improve patient comfort and reduce the work of breathing. Question 5. What do you think is the best approach to monitor high flow oxygen therapy patients? Is it ABG every 24 hours, B, continuous SpO2 monitoring only, or C, combined clinical assessment and ROX index trend, or D, chest X-ray monitoring? Correct answer is C, combined clinical assessment together with ROX index trend. Last question we have for today is, what is the correct formula for the ROX index? Correct answer is C, SpO2 divided by FiO2, altogether divided by the respiratory rate, as it integrates both oxygenation and the respiratory effort of the patient. Thank you for listening, and that was our case-based discussion on patients with hypercapnic respiratory failure. Thank you all.
Okay, thank you very much, Shireen, and all the speakers. It was very nice elaboration on high flow nasal cannula effect on hypercapnic respiratory failure. Actually, it's a hot topic, and I think still we need more studies on this topic, especially the use of high flow just started after the COVID pandemic, and most of us, we just start to use it over the last 5-6 years. So I think we still need more evidence on this. For myself, in practice, I usually combine both. I cannot use like just only high flow and a patient who had hypercapnic respiratory failure. Usually we combine it with BiPAP, and like it depends on how the patient responded to this. And most of the time it works actually very well when you combine to high flow. Some patients are really non-tolerant to non-invasive BiPAP, so we have to use something to support them, and I think high flow fits very well on those type of patients. Dr. Ashraf, you want to add any comment on this?
Ashraf Tarifi, I totally agree with you, Dr. Sultan. I think in reality, we combine both modalities together. So for ease of use, you start high flow, and then you could alternate with BiPAP. My question to the speakers, for example, Dr. Fadi, what do you think is a practical approach? Somebody comes to you, COPD exacerbation, patient is in the ER. Patient, let's say in mild to moderate exacerbation, what would be a practical approach regarding ventilatory support? And then we'll hear from Dr. Heba as well.
Thank you, Dr. Ashraf. So I think that the main challenge, or the main question in my mind when I assess such a patient, you said it's mild to moderate. So, but the main question for any patient with COPD exacerbation is that, does he need immediate mechanical ventilation, I mean invasive mechanical ventilation, or not? So that will be more reliable for me on two main factors: the level of consciousness. So would the patient be cooperative regardless whether it is high flow or non-invasive? He has to be cooperative with me. So level of consciousness plays a role in that decision. The other thing is the degree of the respiratory distress. So if the patient, he needs respiratory support from the point that I feel that he's distressed, he's using accessory muscles, his respiratory rate is high. So if this is combined with the stable level of consciousness, so I would not really lose time in using the high flow nasal cannula or non-invasive ventilation. I will go directly to intubation, because otherwise I'm just delaying the decision of intubation. I'm doing crash intubation and putting the patient at risk of this crash intubation. Now, if the patient, his level of consciousness is good and his level of distress is high, so I feel that he's actually working hard and he's spending high cost regarding the breathing, so that means that he needs the pressure. So the high flow nasal cannula for me, it's not really a tool of applying pressure. So the high flow nasal cannula for me so far, according to my experience, is actually a method of delivering oxygen. Now, it's a byproduct that we are gaining the CO2 clearance, but this is just a humble CO2 clearance from the high flow nasal cannula. So you don't expect to have a huge CO2 clearance. So it's not really a method of applying pressure. So if your patient is in distress, then you need a method of applying pressure, and in that way it will be non-invasive ventilation. So as you mentioned, that most of the time we alternate between the two methods. Before the high flow nasal cannula, we could not use actually other than the non-invasive ventilation and the conventional oxygen therapy. We were limited by the non-invasive ventilation from the claustrophobia, all these naughty and disadvantages or disadvantaged adverse events from the, or adverse, sorry, side effects from the non-invasive ventilation, the pressure ulcers. So I would use the non-invasive ventilation briefly, let's say like session of 2 hours, maximum 3 hours, until I relieve the muscle fatigue of the patient. I get improvement in the CO2, which will actually reflect on the level of consciousness of the patient, and then I give him the rest on the high flow nasal cannula. So the high flow nasal cannula will maintain for me for, let's say, like for a couple of hours, as we said, humble level of clearing the CO2, but not as optimal as the non-invasive ventilation. So high flow nasal cannula, it's a humble way of managing those patients. But if my patient, he has high respiratory distress, he's working hard, I will not really start with high flow nasal cannula. I will start with non-invasive ventilation, relieve him for a couple of hours, and then I will switch and give him rest with high flow nasal cannula. And then according to him, if he starts to build up the CO2 again and he starts to get distress again, then I will apply the non-invasive ventilation again for a couple of hours to give him relief. All of this until I actually reverse the pathology, because all of these are supportive measures until I reverse the pathology of the acute exacerbation of his COPD by steroids, bronchodilators, and antibiotics.
Dr. Hiba, also a practical approach, please.
Dr. Hiba, you are still mute.
Okay, so I do agree with Professor Fadi, is that these patients, the more they are distressed, the more the acidotic, the more critical they are. We don't have the luxury of time to try a modality that is not 100% effective or is not very good, has very good effectiveness in washing out CO2. So we usually start with non-invasive ventilation, but the problem is that these anxious, distressed patients, most of them are very claustrophobic. Usually they see the mask and throw it away. So it's a matter of monitoring, and it's a matter of reassurance of the patients. And you have to talk with your patients and explain for him different interfaces. And then he feel comfortable with this interface. And then you say to him, okay, I'm going to take off this and put you on this nasal cannula in order to speak and talk and so on. So these modalities complement each other. And I see that the high flow nasal cannula increases the success of non-invasive ventilation. In other words, patients that are dependent on non-invasive ventilation, when they are put on long hours, They have these ulcers, they have this claustrophobia, they cannot talk, they cannot eat. But when I just remove this non-invasive ventilation and start to talk with my patient and reassure him and put the high flow nasal cannula instead of conventional oxygen therapy, I do increase the success of this modality in patients that are distressed and are in acute state. However, patients who are more stable and more chronic patient, usually I prefer to start with high flow nasal cannula so long the patient is not acidotic, so long the patient is stable, but he came with an exacerbation with hypoxia, some sort of tachypnea, but he's not acidotic. I prefer to start with the high flow nasal cannula, and it's all a matter of monitoring and phenotyping of your patient with the tools beside you, and you have to be closely monitoring your patient.
Dr. Ashraf, Dr.
I
Sultan.
just have a follow-up, Dr. Fadi, if you allow me, just have a follow-up question. Which is more important in managing the patient? Is it the patient comfort or actually lowering the CO2? When somebody comes in and they're distressed and you're afraid that they might need to be intubated, is the priority for patient comfort and relief of distress, even with the same level of CO2, or is it lowering the CO2 and having the pH in a safe range, in a practical way? What do you think, Dr. Fadi, and then Dr. Rahiba?
So I think they should go all in the same direction. You cannot expect that you will have a patient who gets relieved and his level of consciousness improves and he gets less anxious, and at the same time the CO2 is not improving. That does not make sense. I mean, that will not make sense. So his CO2 should start to improve, because as long when the muscles they start to get relieved and his minute ventilation improves, and actually his bronchospasm improves, which means that his alveolar ventilation improves, then his CO2 should reflect. It might take a bit some time, maybe an hour to improve. It will not really improve within half an hour or 15 minutes, but they should go in parallel. They should go all in parallel. This is according to my expectation. Now, just from this is according to your question, but for the point which Dr. Hibashi mentioned, just my caution or my fear or from the high flow nasal cannula is that over reliance or unrealistic reliance on the high flow nasal cannula, that I receive a patient with COPD exacerbation, I put him in high flow nasal cannula, especially that sometimes those patients, they are not really kept in the ICU or step down, they are kept in the floor. So keeping those patients in the high flow nasal cannula without close monitoring, as we said, regarding level of consciousness, their CO2 level, their muscle, their work of breathing. And I would say, again, I stress on that point, the work of breathing, because many of the juniors, they do not really stress on that point, the work of the breathing. So keeping them in unmonitored area and just leaving them in high flow nasal cannula and putting all their confidence in the high flow nasal cannula and coming back after 1 hour, that's really dangerous. And I think there was one of the questions in the Q&A is about the using of the high flow nasal cannula in the home setting, and how would you manage those patients when they develop acute exacerbation at home. That, I think that will be very dangerous, because such patients, when they develop acute exacerbation at home and they are already in high flow nasal cannula, and the family, they continue using the high flow nasal cannula at home without any tools for monitoring, that will be very dangerous.
Yes, I think the study that answered this question about those patients, they talk about patients that are the chronic patient that use long-term oxygen therapy, and they are stable patient. They are not tachypnic, they are not hypoxic. I mean, they are put. It was a comparison between the long-term oxygen therapy and the high-flow nasal oxygen 4 hours per night regarding the exacerbation rate. But you are right, we have to put tools for monitoring to such patient, and we have to educate the patient how to monitor yourself and see that you are on the right track. And it's still an area of research. It's not done on clinical basis that we prescribe high flow nasal cannula for stable COPD patient at home. We do not do this. This is a new area of research, and whether this modality will decrease the risk of exacerbation in these patients.
Excellent. طيب, we'll take some questions from the audience. So Yusuf is asking about the use of non-invasive and high flow in a patient on negative pressure ventilator. Do you have any idea about this negative pressure ventilator? Did you use them?
Actually, for me, I did not use it. I just read about it, and I find that it's a very promising modality that combines both benefits of the non-invasive ventilation without this mask and this ulcers and leaks and so on, and claustrophobia, unloading the respiratory muscles with the negative pressure ventilation, together with providing humidified, heated oxygen that cause comfort to the patient and cause CO2 clearance. So I find it a very nice idea and a good modality. However, it needs more research to see how it will be implemented in clinical practice.
Yeah, I haven't used them, and I haven't seen them actually in live, but I think it's something that might be in the future. Ashraf, did you use them or?
No, I have no personal experience and I have not seen it personally.
Fadi, any
No,
idea about?
I did not see any of them. We really just read about them, about the iron lung, and I don't really imagine they are not yet in the market. We don't really have evidence about them. So I think that we should not really bother ourselves much about them now.
It's very interesting, actually. It's like wearing a jacket around the chest, and this will apply negative pressure. I think it's a way to overcome the muscle fatigue in patient with like COPD exacerbation or patient with advanced lung disease. But I think we still need more
very good
practice and.
In patients with neuromuscular disease and muscular dystrophy, it will be very good and excellent idea because these patients usually on home ventilators, so this will be excellent. But we need to see how it could be implemented, and we see the machines and gain experience.
Yeah, exactly. Dr. Subhan, just a
Yes.
point. I think it might be that the high flow nasal cannula for patients with neuromuscular diseases, especially when they are without having, let's say, like a flare up, not really flare up, without having a pneumonia or not really exacerbation or without having additional factor, high flow nasal cannula, it might be a good method for use at home use to relieve their hypercapnia, especially when their ventilatory pump, especially if their ventilatory failure is in the beginning.
Yes.
Yeah, that was the next question about how to provide high flow at home. I have seen actually one of the companies here. They showed me their machine. It's a small machine which can provide up to 40 liter of high flow at home. There is like a special pump for it. I think it's a promising thing, but not in COPD patient. Maybe in other
How much
types of.
high flow they can provide?
It can provide 100%, like the high flow at home in the hospital.
From the room air?
No, it will be connected either to like oxygen concentrator or to cylinder.
Yes, we've used that a lot in Egypt because usually in the pandemic, in COVID, there was shortage in the hospital, and we usually managed patients at home as if they were in the hospital. And there were companies that were buying this product and usually use it in COVID patient and attach it to the oxygen concentrator with 10 liter capacity, and it was working very good, although it's very expensive.
Yeah. Right. Next question is from Noor Muhammad. Is asking about he wants more clarification on this asymmetrical bronze of high flow.
Okay, so the asymmetrical bronze, its idea about occluding one of the nasal cavity, when you just occlude this nasal cavity, so no air will escape. So this allow for increase the PEEP, so this PEEP effect will be augmented. However, I could not increase the diameter of the two nasal bronches, occluding both nares, because occluding both nares may increase the airway pressure to levels that we don't want, that may ameliorate the patient, especially if the patient has his mouth closed. So occluding both nares with a high pressure without leaving an air to escape, this would not be a good idea. So this is why they innovated the idea of occluding one nair to increase the pressure without harming or causing such marked increase in airway pressure by allowing the other nair with the small bronch. This is the first part. The second part is creating a pressure gradient between both nostrils. When you put wide bronch in one nasal cavity, it creates an increased pressure in this cavity. On the other side has less pressure. So they find this difference in pressure between both nostrils pushes the air out, pushes the CO2 out quicker than those two symmetrical nostrils where both air escapes in both directions without pressure gradient. This was done on simulation of the nasal cavity, and it also were done in humans, different studies. They measured the pressure, they measured the PCO2, and all of these studies gave promising results. So this is a new technique, a new interface that is under study.
Okay. Okay. I think we exceeded our time. There are like 2 more questions here. One question about are there studies investigating the harm effect of high flow nasal cannula on nasal mucosa? Do you have any answer to this?
I didn't really come across any of them because actually I was handling the cons about the nasal mucosa. To be honest, no, I did not really come across any of one of them.
I think it would not be much such harm because usually these patients, we put them on low flows, like 30 to 40 liter per minute would not cause so much irritation. Those irritation that we find it when you increase the flows in patients that were hypoxemic. So I think this nasal irritation issue is related to increased flows that we do not use in hypercapnic respiratory failure. So I don't think this is an issue in these patients because we use low flows, which is 30 to 40 liter.
Yeah, and what I notice in practice that if you keep them on high flow for a long time, like days, this might cause bleeding from the nasal like mucosa and
even with low flow,
even with low flow, because it will cause some dryness on the nose and might cause bleeding. I have seen it like a few patients, but like something that needs, I think, to be studied and investigated. Final comment from Dr. Shireen, and we'll conclude.
Thank you. Thank you, Professor. Finally, we can conclude from all these lectures and the elegant comments that high flow nasal cannula may be used in hypercapnic respiratory failure when it's mild to moderate in case without acidemia. Especially if there's no signs of increased work of breathing like severe tachypnea or altered consciousness or severe signs of respiratory failure, only in mild cases, it may be a very good option, especially providing the heated and humidified gas, allowing for better physiological mucociliary function. So high flow nasal cannula or high flow oxygen therapy generally might be a very good option for patients with mild cases of hypercapnic type 2 respiratory failure.
Thank you so much, Dr. Shireen, Dr. Fadi, Dr. Heba, for the great presentation and for our great moderation by Dr. Sultan and Dr. Ashraf Al-Tarifi. I think we came into the end and the conclusion of this fantastic webinar. Just a couple announcement. Tomorrow you should all receive the YouTube link of the recorded webinar, and hopefully you will enjoy watching it over and over. Next, also all attendees should get certificate of attendance by next week. Stay tuned for our next webinar, which will be on next month on April 20. This will be in collaboration with the International Fluid Academy, and the focus will be the new guidelines for treating pulmonary embolism. So we'll see you all next month, and have a good afternoon, good evening, everyone.
Thank you.
Bye.
Thank you very much.